Well, hello there. Hello. I'm Professor Fundus, and this is Specialty Nursing, an educational space where nursing minds can learn and grow together. Supporting your nursing journey is our specialty. Does this look familiar? Caffeine give me strength. Create a plan of care utilizing the nursing process. Chief complaint. Mr. Smith is a 28-year-old male presenting to the ED. Sallow, pale, and diaphoretic. Was this dumb? Oriented to person and place, but not time. Was nursing school a bad choice? Patient reports abdominal pain started about a week ago and has been getting worse. C's get degrees. Patient reports 10 pounds of weight gain over the last month. C's get degrees. I can do it. Same, buddy. Patient emphatically states heavy alcohol use. Heart rate 120. Prefers vodka. Blood pressure 150 over 90. The sheer volume of data a nurse must collect, assess, utilize for basic patient care is staggering. It's like needing a sip of water, but instead being blasted by a fire hose. It's a lot to take in. If you've ever felt like you're drowning in information, you're definitely not alone. I got you. The nursing process is the fundamental framework in which nurses can build each patient's plan of care. This framework is broken down into a series of steps using the acronym ADPIE: assessment, diagnosis, planning, implementation, and evaluation. This framework approach requires a look at the person and their health as a whole. For example, I might be an enthusiastic yet frequently anxious mess in a white coat with heartburn and a missing gallbladder, but I, like our patients, am more than the sum of my parts, or lack of parts. I'm a whole person, sometimes. This is a big picture thing. How can I explain it in a simple, tangible way? I have something that'll help. Let me see if I can find it. Hang on. Sing along if you know this one. Old classic. A is for the way I look at you. And by look at you, I really mean visual inspection. It goes along with auscultation, percussion, light palpation, etc. D is how your body's being rude. Disease process, pathophysiology, etiology. P is a very, very detailed look at what we'll do. I, all the ways I take care of you. Evaluate is how I check on you. Care is simply what we nurses do. Here's a cup, now take it, fill it up, but please don't break it. And that's enough of that. Let's review our case study of Mr. Smith through the lens of the nursing process. The assessment piece is all the heavy stuff right up front. That includes chief complaint, history of present illness, past medical history, which can further include medical history, surgical history, family history, social history, any other data you may need to collect. Subjective data, which is what the patient reports to you. Objective data that you observe in your own assessment. The chief complaint is abdominal pain and nausea and vomiting. History of present illness. Mr. Smith is a 28-year-old male presenting to the emergency department with abdominal pain and nausea and vomiting times 2 days. He appears sallow, pale, and diaphoretic. The patient is oriented to person and place, but not time, and he appears sleepy and confused, with speech slightly slurred. No signs of facial drooping. Movement and strength of limbs are equal bilaterally. Patient reports abdominal pain started a week ago and has been getting worse, especially when laying down. The patient reports 10 plus pounds of weight gain over the last month. His roommate brought him in after finding the patient unconscious on the couch, stating the patient has been feeling ill for the last month and stopped going to work this week. Patient emphatically states, "I feel like a sack of Past medical history. Patient has a history of depression and has been non-compliant with SSRIs. He's been pre-hypertensive for the last year and has a history of alcohol abuse and tobacco use. Surgical history includes a lap chole 2 years ago. Social history patient lives in an apartment with 3 male roommates. One roommate brought him in after finding him passed out on the couch. The patient works as a construction worker, has minimal family support as his parents are far away and out of state. He smokes 2 packs of cigarettes a day, and the roommates report heavy alcohol use, and the patient ingests at least a fifth of hard liquor per day. He prefers vodka. He has an allergy to penicillin, which produces hives. The last time he received penicillin was at the age of 10. Medications include sertraline, 10 milligrams daily, and the patient reports, "I take it when I remember." And 2, he takes an over-the-counter ibuprofen, 600 milligrams Q6 hours. Vitals include a heart rate at 120, respiration rate at 22, blood pressure at 150/90, temperature 98.0, oxygenation is 98% on room air. His abdominal pain rates 6 out of 10. Eyes, no vision changes. Perla, yellowing of sclera. Skin is pale and jaundiced. Cardiovascular, 2+ edema in the lower extremities noted. Bounding pulses palpated at all sites bilaterally except 2+ at the pedal location. Pulmonary, mild shortness of breath and tachypnea. GI, nausea and vomiting times 2 days. Abdomen, moderate abdominal distension, tender upon palpation. Neuro, oriented to person and place but not to time. Appears confused and drowsy. Speech is slightly slurred. As you can see, there is a lot of information included in that assessment piece. It is the physical examination, it's the taking of a history from the patient and potentially family members, friends, whoever brought them in. Diagnosis is the medical problem that we must treat, and the diagnosis drives the plan of care. What's the matter with them right now? Mr. Smith's assessment is quite telling. He is complaining of nausea and vomiting as well as abdominal pain, weight gain of 10 pounds in the last month, has a history of heavy drinking, has yellowing of the skin and eyes. It's painting a picture that his liver is not doing very well. Perhaps it's alcoholic hepatitis, alcoholic cirrhosis. Either way, the liver is not doing well. While nurses don't make the medical diagnoses, we can still use them in our plan of care. To get an official diagnosis, that will come from the physician. Often after running a set of diagnostic tests. That may include lab work. For this patient, that could include a CBC and CMP, an abdominal ultrasound to take a look at third spacing, fluid, ascites, and those findings will help inform our plan of care. Planning is often complex and multidisciplinary. The patient is here with this problem. We want to maximize their outcomes. What is it that we need to do? What information do we need to gather? What specialties need to be involved? The planning phase is where the rubber meets the road. The team must assemble and create a plan to get this patient on the road to wellness. Perhaps the lab results show us that there's acute kidney injury on top of the liver issues and we need a nephrology consult. The patient will require an array of medications, something to treat this hypertension, the edema, the ascites, and something for pain besides ibuprofen. It's not great for the liver. The patient has been scheduled for a paracentesis to draw off extra fluid in the abdomen. Implementation is how the plan is set in motion. In my own practice, I like to separate nursing actions into 3 separate pieces. Prevention, what you do before the problem occurs. Intervention, things that you do while the problem is currently happening. And management, the problem happened, now what? In acute care settings, the preventive step might be too little too late. They're already here, it's already happening. Prevention isn't really in the game plan yet. However, we can identify if there are preventative steps to help mitigate further loss. Is there something we can do to prevent further complications with comorbidities? Things like that. I consider intervention as the here and now. They are sick, it is acute, how can I fix it? Management is the third piece. It's the where do we go from here? The acute issue has passed. It may or may not have changed us. The problem occurred. We addressed it. Management is about maximizing what we have left. What changes can be expected in the activities of daily living? What education needs to be provided? For implementation, our nursing actions will take the form of prevention, intervention, and management. It's a little late for prevention at this stage as our patient is already jaundiced and displaying pretty severe symptoms. The patient has been smoking and drinking heavily. The patient may have benefited from screening or education earlier. Interventions may include promoting physical and psychological comfort, the administration of medications, Management is going to look at the result of this acute issue. Will the patient's daily life be affected by this hospitalization? What lifestyle and behavior changes will be necessary to promote health? What resources are available to the patient? Evaluation is both formative and summative. Formative evaluation is performed on the go. As you carry out this plan of care, is it working? Are there new pieces that we've discovered? Has new information come to light that we need to add into the plan? If so, let's do it and keep checking. Summative evaluation comes at the end of a plan of care. It is a retrospective look at the treatment as a whole. Were our care goals met? Were there positive patient outcomes? Were any injuries sustained? What went well and what went poorly? The evaluation step takes a look at our plan of care to see if it was effective. Were our patient goals met? For instance, have we been able to bring the blood pressure within normal limits? Has the edema resolved? How is the abdominal fluid accumulation looking now? Has the patient's pain been managed effectively? Is Mr. Smith stable enough to go home? This isn't the end of the journey. It's just a curve in the continuum loop that is ADPIE: assessment, diagnosis, planning, implementation, and evaluation. Thank you so much for joining me as we've discussed the nursing process through ADPIE. I hope you found this discussion helpful. More helpful nursing content in development. I encourage you to bloom where you've been planted. You are unique and special and have something amazing to bring to your patient population. For now, I'll say oolong, farewell, take care of yourself, be well.